Hi, welcome to our Star Connect series. Today we will be talking on fetal growth restriction. We all know how to define fetal growth restriction. What is important is what it has been classified now with the two important things: early onset fetal growth restriction less than 32 weeks or late onset fetal growth restriction that is more than 34 weeks. We all know the common etiology may be maternal condition, placental, umbilical, or a fetal. But very important to do the risk stratifications. The risk factors one should find out in a growth restriction fetuses. One, it may be from the history. Second, there may be associated medical conditions like chronic hypertension, kidney diseases, and all. It may be the obstetric history, previous pregnancy, there may be, or the biochemical markers, low PAPA, low PIGF, or ultrasound based markers, high pulsatility index, and other things. This all will help us to identify it very early. Woman with the suspected fetal growth restriction should undergo then systemic analysis. You take her detailed history, confirm her gestational age again, it may be a wrong date calculation, detailed sonographic assessment, the Doppler study, and then the maternal condition screening for toxo, for any other viral, syphilis, malaria, and other high risk factors has to be taken out. Let's concentrate today. I want to tell you in 3 minutes what should be the management of this fetal growth restriction. This is a very complicated chart. So I'm going to talk to you about how we can simplify. One, pre-viability, that is before 26 weeks. 26 to 30 weeks, early viability. 30 weeks to 34 weeks viability, and after 34 weeks the NICU. You have to make this chart in your mind, but there are certain absolute indications you can read in these slides. With these absolute indication you have no choice. Even if you are in a pre-viable stage, you need to terminate. But there are certain relative indications where biophysical profile around 6 by 10, you may be thinking, waiting, you may be able to continue. So if I talk about it, what we can think about is in case of isolated mild. Now remember 5 important points I'm going to tell you. In case of a isolated mild small for gestational age, there is no additional abnormality in that patient, no abnormal fluid or Doppler or anything, only isolated, and it's a mild. Please continue the delivery till 37 to 39 weeks, and monitoring we can be done at the interval of 1 to 2 weeks. In case of isolated severe IG, that is less than 3 percentile growth rate which is happening, but there are no additional abnormalities, you can defer till 36 to 38 weeks. And what is important is till that time on a OPD basis, you keep on doing her Doppler studies maybe once a week or twice a week. Now in cases of small for gestational age with early Doppler changes, now the Doppler changes or some associated problem, that is PIH or oligohydramnios, then still keep a close monitoring with the Doppler and biophysical profile, and still you can continue till 34 to 37 weeks of pregnancy. Now, in cases with umbilical artery absent end diastolic velocity, you can still defer till 32 weeks. But make this patient hospitalized and monitor her very closely, not only with the CTG and ST or biophysical profile, but also Doppler thrice a week, that is alternate day Doppler, keep on doing with the absent end diastolic velocity. And in case of a FGR with umbilical artery reversed end diastolic flow, again you can continue the pregnancy, at least try to make it till 30 weeks of pregnancy, but hospitalize the patient, and here you do the daily Doppler, not alternate day, daily Doppler, and maybe twice a day biophysical profile checking. This is very important to understand. And then when we have taken the pregnancy near term, do we need to do the cesarean because they are high risk? No. Caesarean is not considered as a primary indication that fetal growth restriction is a primary indication and do caesarean. It is not that. But if it is a maternal problem, like severe preeclampsia or any contraindication for vaginal birth, or if there is a late umbilical artery or ductus venosus Doppler changes, then you can think about doing a cesarean section. Delivery of a fetal growth restricted fetuses should ideally take place in a center with excellent neonatal care. Remember, shifting the neonate from one unit to another to the specialized, it's little bit turbulent phase. Better ask the patient to go and deliver in that center where there is an excellent neonatal care, who are having a setup to manage as early as 24 to 28 weeks of pregnancy. Also, don't forget to send the placenta for histopathological examination, because you need to know the cause why this has happened unless you have a very obvious cause with you. Friends, don't forget the important role of corticosteroid and Maxal in these patients. Thank you so much. I hope you all are enjoying my this small series of Star Connect, where I am trying to connect with you all. Thank you.